Hey everyone, welcome back to my channel. If you don't know me, my name is Jennifer Lyons and I'm a veterinary technician specialist in emergency and critical care. If you don't know what that is, please reference my first video. This channel is all about veterinary medicine and specifically emergency and critical care nursing skills. At the beginning of each of my videos, I'm going to have a slide highlighting key terminology that I'll be using throughout the video. For today's video, our key terms are mostly prefixes. They're going to be hypo, which stands for low, hyper, which is high, brady, which is slow, tachy, which is fast, and perfusion, which is the term for blood delivery to tissue and organs, and hemodynamics, which is the physiology of perfusion. Today I want to talk about performing a TPR. If you're watching this video, you probably already know that TPR stands for temperature, pulse, and respiration, and it's basically considered a shorthand way of saying vitals or vitals assessment. A TPR should be performed on every patient that enters your hospital every time. That means even patients that are just there for a tech or nursing exam, patients that are there for suture removal or for drain removal. If you have a hospitalized patient, you're likely going to be performing a TPR or vitals assessment on them every few hours. If they're stable, if they're not stable, you may be performing it hourly or more than that. For patients that are anesthetized, you're essentially performing continuous TPRs by monitoring their anesthetic vitals, but you should be recording your vitals assessment at least every 5 minutes. So why are we performing a TPR? Well, a TPR is like taking a snapshot of your patient. You can capture a momentary picture of what is happening with that patient at that time, and for a brief minute you can see into that patient's hemodynamic state and cardiovascular stability. Once you have a TPR, you should feel confident in saying, yes, this patient can wait to see the doctor, or no, this patient needs to be seen sooner. Even though TPR just stands for temperature, pulse, and respiration, if you're using it as a shorthand term to say vitals or vitals assessment, there are a couple of other parameters that we should also be measuring. A real TPR or vitals assessment includes an entire nursing exam, which covers a temperature, a heart rate and pulse assessment, a respiratory rate and respiratory effort assessment, mucous membrane evaluation, a capillary refill time, a pain scoring, and a mentation or level of consciousness examination. Your vitals assessment begins the second you visualize your patient. As you enter an exam room or walk up to the lobby, or if you're still curbside, as you walk out to their car, you can start assessing your patient. You can be looking at their mentation, at their respiratory effort, and you can just start to get a sense of the overall sickness or health of your patient. An important part of an efficient TPR includes multitasking. So you should be able to start your TPR while you're getting a history from an owner. You don't have to wait for them to stop talking for you to start listening to them or to start taking their temperature. If you're still curbside and you're taking your history over the phone, keep in mind that while a lot of owners do overestimate the sickness of their pet, a lot of owners also underestimate it. Try to keep your history short so that you can get your patient and start performing your TPR. When I'm performing my vitals assessment, I like to start with the least invasive vitals first so that my patient can start to get comfortable with me. So usually it's easiest to start by petting your patient and quickly slipping your hand over their chest so you can palpate a pulse rate, or if they'll let you, slip your hand over their femoral arteries so that you can evaluate their pulses there. You can also lift up their gums so that you can check their mucous membranes. You can auscultate them with your stethoscope, but I usually leave the most invasive thing for last, which is your temperature. So the first component of our TPR is going to be measuring temperature. Temperature can be measured a few different ways. It can be measured rectally, which is the most common way, orally, and that's AU for in their ear, or axillary, which is the term for measuring it under their armpit. If your patient is anesthetized, you can also have an esophageal thermometer. The most accurate method for evaluating temperature is going to be the rectal thermometer, but it's also the most invasive and it's not practical in every patient, which is why having just a human thermometer that's used in the ear, having that handy can be really helpful for aggressive patients or patients that are just very stressed or anxious. But keep in mind that these human thermometers are not always incredibly accurate for pets. There have been a couple of studies done comparing rectal temperatures to oral and axillary temperatures, and they found that on average, an oral temperature can vary by up to 1 degree from a rectal temperature, and an axillary temperature can vary up to 2 degrees from a rectal temperature. So it's really important when you're measuring temperature to make sure that you're doing it consistently. If you have a patient that's hospitalized and you're monitoring their temperature every hour, every couple of hours, making sure that you're doing it the same every time can help to provide good information on trends. Sometimes the trend of a patient is more important than that snapshot in time. Another important aspect of consistency is making sure that everybody in your clinic is measuring and writing down their temperature the same way. So if it's standard at your clinic to measure a rectal temperature and everybody is writing down their rectal temperature on their triage sheet, but you have an aggressive pet and you have to do an axillary temperature on them, are you going to be writing down their temperature with the +2 degrees Fahrenheit conversion, or are you writing down the temperature before the conversion and then just writing the word axillary underneath? It's really important because then your clinician has to assess, was that with the +2 degrees or before it? So if their temperature is 103, is their temperature really 105? For the normal reference ranges for temperature, you're gonna get a different range depending on what reference you're reading. Different textbooks will list different ranges as normal. For me, in general, I consider a normal temperature anywhere from 99.5 up to 103. You're gonna see a lot of sources saying up to 102.5 or a low of 100. None of these are wrong, they're just different references. Keep in mind that your anxious pet will often have a higher temperature than normal. So if you have a crazy, anxious young lab with a temperature of 103.5, it might be worth trying to retake their temperature after they've had some time to settle down to see, is that really an elevated body temperature or were they just anxious? An important note here is that just because the temperature is elevated does not mean that pet has a fever. True fever has very specific causes, and there are different causes for elevated body temperatures or hyperthermia. In our video about triage and stabilization, I'll be reviewing the causes of fever and the difference between hyperthermia and pyrexia, which is the term for fever. Our next vital parameter is going to be the heart rate. And we should get a heart rate by listening to our patient. Palpating for a pulse is considered a pulse rate, not a heart rate, because these two numbers can be different. So you should get out your stethoscope and you should listen to your patient's heart. You can listen from the left side or the right side. I like to do both because the heart can sound different from left to right. In cats, you should listen peristernally, which means kind of just in the middle of their sternum. Oftentimes cats will have heart murmurs that are very focal to the peristernal area. While we're ausculting our patient, we should also try to palpate a pulse rate. The easiest pulse to palpate while you're listening to them is the femoral pulse, and you can palpate that by sliding your hand to their inner thigh, and you should be able to feel their large femoral artery pulse easily there. This can take some practice, especially in obese pets where they have more fat in that area, and that's going to be something I also review in our triage and stabilization videos. You can count your heart rate in beats per minute. And the longer you listen to your pet, the more accurate heart rate you're going to get. You should try to listen for at least a minute. This will give your pet time to calm down, which should also lower their heart rate a little bit. It will also give you the opportunity to listen to see if you hear any arrhythmias. You can have very intermittent arrhythmias that you won't catch if you're not listening for an extended period of time. To calculate your heart rate, you need to count a number of heartbeats in a specific set of time. Typically, we use either 6 seconds, 10 seconds, 15 seconds, 30 seconds, or a full 60 seconds. Like I just said, longer is better, but there are certain situations where you won't have the opportunity to listen to your pet for very long, such as if your pet is not stable and crashing, or if your pet is aggressive. Make sure you know how long you're counting for so that you know by what factor to multiply to get an accurate heart rate in beats per minute. If you listen for 6 seconds, you can multiply that by 10. If you listen for 10, multiply by 6. If you listen for 15, multiply by 4, and so on. Like for temperature, your heart rate reference ranges are going to vary based on the source that you're looking at. But I'm just going to tell you the reference ranges that I typically use for normal in cats, small dogs, and large dogs. In the cat, usually the heart rate will be somewhere between 180 and up to 240 if they're very nervous. Much higher than 240 can be hard to count. For your small dog, they should be somewhere between 120 and 160. For your large dog, they should be somewhere between 60 to 140. 60 sounds very low, but in your massive breeds or in your highly athletic breeds, they are going to have lower resting heart rates. Heart rates that are lower than normal are considered bradycardic, and heart rates that are higher than normal are considered tachycardic. We'll go over the causes and the cause of concerns for both in my triage and stabilizations video. The next final is going to be assessing respiratory rate and respiratory effort. Your respiratory rate is breaths per minute, and it is counted the same way as your heart rate is counted in beats per minute. And with a lot of experience, you can actually count both at the same time. Your respiratory effort is a subjective evaluation of how much work your patient is doing in order to bring air into their lungs, which is the act of ventilation, and it's part of breathing. In general, patients can be eupnic, meaning they're breathing normally. They can be tachypnic, meaning they're breathing fast. They can be dyspnic, which means they're working hard to breathe. Or they can be apneic, meaning they're not breathing. Or agonal, meaning they're taking dying breaths. A special note here about the term dyspnea. This is a human term meaning the sensation of needing air or the sensation of having to breathe harder to oxygenate yourself. Because it's a subjective sensation, it's not something that our pets can tell us they're feeling. So in veterinary medicine, we are using the term dyspnea to describe a series of clinical observations that we're making that tell us that the pet is working harder to breathe. So in general, you will hear me use the term dyspnea to mean increased work of breathing. A normal respiratory rate is usually somewhere between 20 and 40 breaths per minute, although dogs are kind of the exception because they can be panting and that can be normal for them. In the panting dog, it is important to assess their work of breathing or their respiratory effort to determine if they are dyspneic or if they're just panting. Tachypnea is the term for increased respiratory rate, and it's very important to note that this is not synonymous with dyspnea. Tachypnea is a pet that is breathing faster than normal, whereas dyspnea is a pet that is working harder to breathe. The term agonal refers to the last few breaths that a pet takes when they are dying, and it's a very specific type of breathing pattern. I'm going to review breathing patterns in my triage and stabilization video, but I do want you to be aware of the term agonal. Apnea is the term for a patient that is not breathing, and you can have apneic patients secondary to a drug that you've administered, or apnea secondary to that patient being dead. I'd like to note here that cats are obligate nose breathers. So if you ever see a cat open mouth breathing, that is an indication of severe respiratory distress in the cat. They should be, 1, triaged immediately, and 2, provided oxygen as soon as possible. The next vitals assessment is going to be evaluating mucous membrane color. Your mucous membranes are the sensitive tissues that secrete mucus that line cavities. And the areas that we can assess mucous membranes are the conjunctiva, the gums, and the prepuce or vulva. Most commonly in veterinary medicine, we use the gums. Normal mucous membranes should be bright pink and moist. If you feel that your patient's gums are dry, that's called tacky, and you can assess dryness based on how much your finger sticks to their gums when you touch it. Your finger should come away feeling moist in a normal patient. If you feel like you're pressing on like Elmer's glue, then that patient would be considered tacky or dry. Color abnormalities for mucous membrane assessment include pale pink, which can be normal in some pets like young puppies, pale, icteric, which is the term for yellow, icteric pale, so yellow gums that are also very light in color, so they don't have a lot of pink or brightness to them. Hyperemic, which is the term for very bright red, brick red gums. Cyanotic, which is the term for blue gums that indicate the patient's not oxygenating. And brown gums, which can be a sign of methemoglobinemia, which is something we'll talk about later. The next vitals assessment is your capillary refill time, or your CRT, and this is the amount of time that it takes for a capillary bed to refill with blood. To assess your capillary refill time, you would apply pressure to an area full of capillary beds. The most commonly used area in veterinary medicine are the gums, which is great because then you can assess your capillary refill time and your mucous membrane color at the same time. So you'll apply pressure, you'll remove the pressure, and then count how many seconds it takes for that area to return to the color it was before you applied pressure. So when you're using the gums, you can assess how long it takes for the gums to go back to being pink or back to being whatever color they were. We can do this in ourselves by applying pressure to the tip of our finger and assessing how long it takes for our finger to go from white to pink. Normal is 1 to 2 seconds. Less than 1 second is considered fast, which is a sign of a hyperdynamic state or a state of peripheral vasodilation. And that means that peripherally, so away from our central organs, the vessels are dilated, or the vessels are large. And if you think about a large vessel, when you put pressure on it, the blood will go away from that spot of pressure, but it's going to sit in those large vessels around the pressure. So when you pull the pressure away, the blood is still there and it'll quickly fill that area again. A CRT of greater than 2 seconds is considered slow and is a sign of poor perfusion or peripheral vasoconstriction. So instead, those peripheral vessels will be smaller than usual. So when you apply pressure to them, the blood squeezes into those constricted vessels so that when you pull your pressure away, it takes longer for the blood to travel through those small vessels to refill the capillaries that you just applied pressure to. In my next video about triage and stabilization, I'll be going over causes of vasoconstriction and vasodilation. The next vitals parameter is mentation, or level of consciousness, also abbreviated to LOC. Mentation is a subjective assessment on a scale, with one end being bright, happy, healthy, to the other end being completely non-responsive. Depending on what sources you're referencing, there will be different terms used to describe different levels of mentation or levels of consciousness. I'm going to go over the terms that I prefer to use. Your first one is going to be BAR, which stands for bright, alert, and responsive. This is your happy puppy that's extremely interactive, bouncy, seemingly happy to be there, maybe just there for a vaccination appointment. A level below BAR is QAR, which stands for quiet, alert, and responsive. And this may be a pet that is maybe older. They're still very interactive with you and with their environment, but maybe they're sitting a little bit quieter. They're not lethargic. They're just not quite as boisterous as a BAR pet. A step down from QAR is depressed. The depressed patient will still interact with you when you go to them, but they may just be not paying attention to their surroundings when they're in their kennel. They may be considered slightly lethargic. A step below depressed is dull. The dull patient is very lethargic, will interact with you directly when you're stimulating them, but perhaps if you're standing them up on all fours, they either collapse down or choose to lay back down with very little energy. You'll see a lot of sources that use depressed and dull synonymously. I choose to use dull as a more extreme version of depressed. A step down from dull is your obtunded patient. An obtunded patient does not interact with you when you go to them and when you stimulate them. They will only interact to extremely noxious stimuli, so extremely painful stimuli. An obtunded patient can usually receive an entire nursing exam, TPR, perhaps even phlebotomy or catheter placement without any response or interaction with you. But if your clinician comes over and attempts to test deep pain by pinching their toes, they should react to some kind of noxious stimuli like that. A step down from obtunded is comatose. A comatose patient is non-responsive to any kind of stimuli. Another common term you might see used for mentation or level of consciousness is status epilepticus. Status epilepticus describes a patient in active seizure. So if you get a triage for a patient that's having an active seizure, you can describe their mentation as status epilepticus. Our last vital assessment is going to be a pain scoring. I'd like to emphasize here that pain is a vital. Painful patients or potentially painful patients should be triaged sooner to assess their need for analgesics. Pain can be difficult to assess in animals because they may either hide their pain or their anxiety may make their pain difficult to assess. However, it is our job from a nursing standpoint to try to assess patients that are painful. Common areas of pain in the pet is abdominal pain, spinal pain, or pain from a traumatic injury. You can easily assess abdominal pain by gently palpating their abdomen and spinal pain by gently palpating along their spine. I say gently because typically your clinician is going to do a much more thorough pain assessment, and you don't want to make your patient difficult for the clinician to assess. For example, if you have a pet that is mildly fractious and you palpate their spine too much and they have spinal pain, they may become too fractious to handle for the clinician to do their evaluation. Pain scoring can be difficult to standardize within a clinic because it is a subjective parameter. There are a couple of veterinary pain scales that attempt to remove the subjectivity and make a more objective assessment. One is the Glasgow Composite Pain Scale. This is certified for the use in dogs that have undergone acute pain, so dogs essentially with a traumatic injury, and it is still based off of their behavior. The second is the University of Melbourne Pain Scale, and for this pain scale, a patient will get a rating between 0 and 27, with any patient that receives a scoring of higher than 10 being in need of analgesics. This pain scale is assessed based on their behavior, their interactions with you during their exam, and their vitals. Unfortunately, neither of these pain scales are particularly realistic to use in a nursing evaluation, and I like to just use a simple subjective numerical scale from 0 to 4, with 0 being a happy patient having no pain, such as a patient that's there just for a wellness exam. 1 being a patient with mild pain, so an example of mild pain would be a patient with mild abdominal discomfort. 2 being moderate pain, such as a patient with a simple laceration. 3 would be severe pain, such as a patient that has a limb fracture. And 4 would be tremendous pain, such as a patient with multiple traumatic injuries like rib fractures, pelvic fractures, patient that was mauled by another dog or hit by a car. So those are the main vitals in our vitals assessment. I'd like to list 2 bonus vitals, which is the blood pressure for 1. Blood pressure is an extremely important value, and it really should be assessed in any patient having undergone trauma so that we can see if they're a candidate for pain medication. The second is a pulse ox, and a pulse ox should be measured in any patient with respiratory disease if it does not distress them. You should never push a patient in respiratory disease, so if the pulse ox is distressing to them, you should forego it. I'd like to note here I'm going to have separate videos on blood pressure and pulse oximetry. That's the basics of performing a TPR. Your next step is going to be to evaluate if your patient is eligible to wait to see the doctor or if they should be seen sooner. And that is the art of triage, which is a much more in-depth version of a TPR vitals assessment. The art of triage will look at the patient as a whole. So instead of just saying my 16-year-old thin cat has a temperature of 99.4, that's below normal, so they should be seen, triage takes into account the entire patient. It might be normal for a 16-year-old cat to have a slightly lower temperature, whereas a young 2-year-old obese cat with a temperature of 99.4 that's there for not urinating should probably get seen sooner. So if you've made it this far, please like this video, subscribe to my channel, and I'll see you next time discussing the art of triage. Mentation is a subjective... James? Oh, big stretch. Tip. There you go. Jade is just here for a vaccination appointment. Jade! A step below that, oh my god, there's so many cats here. There's so many of you.